Physical examination. The physical examination remains an essential component in the evaluation of the acute abdomen. You will able to garner garner valuable information from this step is better inform the next step in the diagnostic pathway. Physical examination will generate a more precise differential diagnosis, and this will allow for the initiation of the necessary therapy and timely manner. Despite the wide availability of the advanced diagnostic imaging, it cannot replace an organized and thorough physical examination. The initial evaluation of all patients should begin with general inspection. Information regarding the severity of the illness can quickly assess upon walking into the room. Symptoms such as diaphoresis, pallor, dyspnea, and decreased alertness can be assessed rapidly and will forward the examiner their serious issues in at hand. For an acute abdomen, the general inspection will be the first evidence of whether the patient has peritoneal inflammation. These patients tend to be very still as movement aggravate their abdominal pain. In contrast, patients with abdominal pain without peritoneal inflammation will frigate at in attempt to find a comfortable position. Inspection of the abdomen is the next step. Attention is focused on the counter of the abdomen. Skin abnormalities, abdominal wall distension occurs in several abdominal processes such as the intestinal obstruction, developmental of the ascites, and the presence of the growing mass and growing mass. Wall distension. The surgical scars should be identified and correlated to the history taken prior to the physical examination. Other skin findings, such as the erythema, blistering, can alert the examiner to the possibility of the soft tissue infection that may require immediate debri- debridement. The ecchymosis can also be indication of the facial necrotizing infection. Additional, it may alert the examiner accidental and non-accidental trauma may warrant further social investigation. In erythema and the blistering possible soft. The histologically, the next step in the evaluation is the auscultation. This maneuver should be done prior to the percussion and palpation. Bowel activity can affected by the manual manipulation. The vascular abnormalities such as arterial stenosis and the arteriovenous fistulas can be detected by the auscultation. Arterial stenosis, arterio, and the vascular abnormalities. Auscultation for the bowel activity is a controversial. It has been thought that the quantity and the quality of the bowel sound heard correlate with the motility of the bowel. Ileus is associated with hearing fewer than one bowel sound every 15 seconds. Hearing of fewer than one sound 15 seconds per quadrant. The conversely and high-pitched tinkling sound is associated with mechanical bowel obstruction. High tinkling associated with the mechanical bowel obstruction. Many argue that history of the flatus and the bowel movement are more accurate at determining the history of the flatus and the bowel movements more accurate at determining whether the patient having a bowel motility issue than the auscultation. A recent preview article cited low sensitivity and positive predictive values for the auscultation bowel sound in normal volunteer patients with the bowel obstruction and the patient's post-operative ileus. They also noted a poor inter-observer reliability for the bowel auscultation. Recording it at 54% auscultation can be helpful but must be correlated with history and other exam finding. The percussions capable of eliciting wealth of the information. The dull resonance is the in the right upper quadrant identifies a liver. The measuring the superior and inferior range of the dullness will give the examiner right estimated liver size. The percussion is useful to determining whether the abdominal distension is due to the excess air or a fluid. The presence of the localized dullness elsewhere in the abdomen should be raise concern of the intra-abdominal mass. The timpani and the hyperresonance is consist with a gas-filled structure deep to the abdominal wall. If the tympani is hard in the right upper quadrant where the liver is located, this indicate there is the air the abdominal wall and the liver intraperitoneal free air should be suspected. The diffuse dullness on the percussion raises suspicious for the fluid-filled abdomen. The fluid waves can created by quick firm compression of the lateral abdominal wall. Waves should then travel medially across the abdominal wall. The percussion can also be useful identifying the presence of peritonitis. A patient with a peritonitis will have the percussion can also useful identifying the presence of the peritonitis. Presence of the peritonitis percussion. A patient with a peritonitis will have the equisite, the tenderness during the percussion of the abdomen and may not be able to withstand the maneuvers. The jostling the abdominal viscera by percussing the flank, iliac crest, and a heel of the extended lower extremity will elicit characteristics of the sign of the peritonitis. The These maneuvers are more reliable for detecting inflammation of the peritoneal lining than historical techniques of deep palpation followed by a quick withdrawal of a pressure, asking whether the pressure or release was most painful. This can be very painful regardless of the presence of peritonitis. This leaves the room for subjective interpretation by the patient. The final portion of abdominal exam is the palpation. Generally this is most informative portion of the examination. It provides details that help you localize the source of pain as well as abnormalities within abdomen. The examiner should begin with superficial palpation away from the area with the most significant pain. The superficial palpation allows for the assessment of masses or fluid collection anterior to the abdominal wall. Whether the pain is associated with these abnormalities, more pressure should then applied. Perform a deep palpation. The deep palpation allows the examiner to assess pain from the intra-abdominal sources as well as a presence of any intra-abdominal masses organomegaly. The diffuse tenderness to the palpation suggest extensive inflammation and delayed presentation of the ongoing disease of the process. Identifying the region of the maximum tenderness will give the examiner likely source of abdominal pain. By identifying the quadrant causing the pain and differential diagnosis can be developed based on the structure within the quadrant. The gurd, girding can be encouraged while performing abdominal palpation. It is necessary to differentiate between voluntary and the involuntary girding. The voluntary girding occurs when the palpation anticipates painful stimulus and tenses their abdominal wall muscle. To prevent this, have a patient lie supine on the exam table. Bend his bend his and her legs to the place of the sole to their feet flat on the bed. Instruct them to take a deep breath while you palpate. These maneuvers result in relaxation of the abdominal wall as well as distracting the attention of the patient, preventing a voluntary gardening. If an abdominal wall tenses despite the above technique, the patient has involuntary gardening, which is a sign of the peritonitis. इनव्हॉलंटरी गार्डिंग व्हॉलंटरी कधी येतात तर हे सगळं अँटिसिपेटचं पेनफुल स्टिम्युलाय आणि टेन्स टू द ॲबडॉमिनल वॉल मसल्स टेन झाल्याने आपण जो प्रेशर देतो त्याच्यामुळे हे होऊ शकतात ते असतात व्हॉलंटरी. पण आपल्याला कोणते बघायचे तर इनव्हॉलंटरी हे कशाचं साईन आहे तर पेरिटोनायटिसचं साईन आहे. पुढे These are the several name exam maneuver associated with the difference between disease process. These can be seen. The Murphy sign for the acute cholecystitis, which involve deeply palpated right subcostal region while patient inspire deeply. If the cholecystitis is present, the inspiration will be cut short due to the pain as a gallbladder encounter the anterior abdominal wall. The obturator and the psoas sign can be useful to identifying relative position of the inflamed appendix. फक्त जी मर्फी साईन आहे तीच कोलेसिस्टायटिससाठी, बाकीचे सगळे अपेंडिक्ससाठीचेच. त्याच्यानंतर येते रोवास साईन सजेस्ट राईट लोअर क्वाड्रंट पेरिटोनायटिस. Murphy sign for the acute cholecystitis, obturator psoas sign for the inflamed appendix, Rosing sign for the right lower quadrant peritonitis. The additional exam often provide useful information. The digital rectal exam provide information about hollow viscous bleeding, resources distal obstruction causing constipation and the obstipation. In women, result pelvic exam will help include or exclude a gynecological source of the lower abdominal pain. A 2014 study found that 290 women of the reproductive age with right lower quadrant pain through have acute appendicitis. 37 had a gynecologic pathology with normal appendix. Pelvic examination may identify this pathology earlier and allow for the appropriate consultant. आपण हे सगळे चार्ट्स ते बघून घेऊया. तर याच्यामध्ये त्यांनी सांगितलेलं की कुठून कुठून काय काय येतंय वगैरे कोणाचं काय हे इथे दिलेलं त्यांनी राईट अप्पर ह्याच्यामध्ये कोणते कोणते आहेत ते. लिव्हर असणारे, गॉल ब्लॅडर डिओडेनमचा D1 to D3 पार्ट असणारे, राईट किडनी राईट युरेटर असणारे आणि राईट लंग आणि प्ल्युरा असणारे. इकडे अपेंडेक्स, इलियम, राईट कोलन, राईट युरेटर, ब्लॅडर आणि राईट ओव्हरी ऑर द टेस्टिकल. इकडे स्टमक, स्प्लीन, पॅन्क्रियास, लेफ्ट किडनी, लेफ्ट युरेटर, लेफ्ट लंग, प्लुरा. सिग्मॅड कोलॉन, रेक्टम, लेफ्ट युरेटर, ब्लॅडर आणि लेफ्ट ओरी ऑर द टेस्टिकल असणार आहेत. ॲबडॉमिनल एक्झामिनेशन सायन्स. सो हिस्ट्रीमध्ये आहे डॅनफोर्ड साइन. डॅनफोर्ड साइन काय? शोल्डर पेन ऑन द इन्स्पिरेशन दॅट इज हिमोपेरिटोनियम. इन्स्पेक्शनमध्ये द क्रुवे हायड साइन, कुलेन साइन, कलेन साइन, ग्रेटर्नर साइन आणि रॅन्सो हॉप साइन. तर त्याच्यामध्ये असतं कुरिहन साइन म्हणजे व्हेरिकोज वेन ॲट अम्बिलिकस. पेरी अम्बिलिकल ब्रुझिंगला आपण कुलेन साइन म्हणतो. ग्रेटर्नर म्हणजे लोकल एरिया ऑफ द डिस्कलरायझेशन नियर अम्बिलिकस अँड द फ्लॅग्स. द रॅन्सो हॉप्स म्हणजे येल्लो डिस्कलरेशन. आणि याच्या सगळ्यामध्ये एक आहे पोर्टल हायपरटेन्शन, हिमोपेरिटोनायटिस, ॲक्यूट पेरी पॅन्क्रियाटायटिस आणि रप्चर कॉमन बाईल डक्ट. पाल्पेशनमध्ये असतं ॲरॉन साइन, बॅसलर साइन, ब्लमबर्ग साइन, कॅर्नेट साइन, चॅन्डेलियर साइन, द कॉर्सियर साइन, द फोर्टर गिल साइन, इलियोसोवा साइन, मर्फी साइन, ऑब्च्युरेटर साइन, रोजिंग साइन आणि 10 हॉर्न साइन. मर्फी, इलियोसोवा, ऑब्च्युरेटर, रोसिंग साइन. सगळे ॲक्यूट अपेंडिसायटिस. फक्त हे ॲक्यूट कोलिसिस्टायटिससाठी मर्फी साइन आहे. ॲरॉन साइन, pain and pressure in the epigastrium, anterior chest and persistent pressure applied to the McBurby point, that is acute appendicitis. Bacillus sign, sharp pain created by compressing appendix between abdominal wall and iliacus, chronic appendicitis, bacillar. The Blumberg sign, transient abdominal wall rebound tenderness, that is peritoneal inflammation. The Carnet झालं. Chandelier sign, extreme pelvic pain with movement of cervix, pelvic inflammatory diseases. Iliopsoas बघा, elevation and the extended leg against the resistance of painful, that is acute appendicitis but retrocecal. Murphy, pain caused by the inspiration while applying pressure to the right upper abdomen. Obturator मध्ये flexion and the extension of the external rotation of the right thigh creates a hypogastric pain. That's the appendicitis. Rousing signs, that is pain at McBurby points when palpating the left lower quadrant. And 10 horn sign, pain caused while gentle traction of the right testicle. That is hypnotismal 10 horn sign म्हणतात त्याला. Laboratory study can narrow the differentiate diagnosis of the abdominal pain. Contains a complete list of the laboratory tests that can assist the workup and acute abdomen. A complete blood count gives several important data points. The white blood cell count can be elevated or decreased. White blood cell decrease setting a acute abdomen. The best evidence of the acute infection, elevated absolute number and percentage of the band cell. Elevated band cells. So it is ideal to send for a complete blood cell count with a white blood cell differential. The low hemoglobin and hematocrit alert care team to source of bleeding that may associated with a source of the abdominal pain. If the hemoglobin hematocrit higher than the normal, one should evaluate the patient for sign of the dehydration. The patients with the abdominal pain should also have a complete metabolic panel sent. Electrolytes such as sodium, potassium, calcium are evaluated as well as renal function tests such as blood urea nitrogen creatine. The, al- the alterations in these values will alert the physician to fluid losses from the diarrhea, vomiting, as well as possible endocrine sources of the abdominal pain, the hyperparathyroidism. The complete metabolic panel contains liver function test that, when elevated, should lead to further assessment of the hepatic and biliary system. The viral hepatitic panel should be sent when a source of elevated liver enzymes cannot be identified. Amylase and lipase are indicated when peritonitis suspected. ते बघूया आता काय तर लॅबोरेटरी टेस्टेस ऑफ फॉर द ॲबडॉमिनल पेन. सगळ्यात पहिली आहे ती म्हणजे WBC विथ डिफरन्शियल हिमोग्लोबिन, प्लेटलेट, इलेक्ट्रोलाइट्स, creatine and blood urea nitrogen, amylase lipase, total and the fraction serum bilirubin, serum lactate level, viral hepatitic panel, urine analysis, urine human chorionic gonadotropin आणि clostridium difficile culture and the toxin असे. The arterial blood glass with the serum lactate measurements the valuable test when evaluating any severely ill patient. In the setting of the acute abdomen, lactic acidemia, sign of the hypoperfusion, acute abdomen and जर लॅक्टिक ॲसिडेमा असेल तर हे सगळं हायपोपरफ्युजनचे साईन आहेत. The depending on the circumstances rises the concern for measuring ischemia. The mesenteric ischemia is a serious condition that significant mortality despite improvement in critical care and can be tricky to diagnosis. In some patients, attempts to identify additional markers specified to the mesenteric ischemia are underway but not yet available for clinical use. The urine studies should be standard laboratory test sent in previous patient with abdominal pain. Urine analysis can give us several point information. The presence of the bacteria, white blood cell and leukocyte esterase in the sample raises concern for urinary tract infection. Bacteria, white blood cell and leukocyte esterase concern with the urinary tract infection. Possibly phenile nephritis. This would account for the parapubic pain and the planchnic pain. The nephrolithiasis and a nephrotic syndrome can be detected by noting red blood cell in urine. Red blood cell in the urine. Cast within the urine should also raise concern for a renal source of the abdominal pain. Cast a renal source of the abdominal pain. Finally, in the woman of the childbearing age, a urine human chorionic gonadotropin level should be sent as her symptom may be due to the complication of the pregnancy. Human chorionic gonadotropin level, complication of the pregnancies. The additional test The additional test should be sent to select the cases. The patients with diarrhea should have the stool sample. Sent to the culture and the OVA assessment. Importantly, the Clostridium difficile culture and toxin measurement should be performed as the incidence of this infection is increasing within a community. Women in the third trimester pregnancy with a right upper quadrant pain, elevated liver enzyme and low platelet should be assessed for the HELP syndrome. क्या आहे हेल्प सिंड्रोम ते बघूया. HELP syndrome. Woman in the third trimester of pregnancy with right upper quadrant pain, elevated liver enzymes, low platelet, HELP.